We are back with a new webinar series on management of diabetes and associated infections presented to you by SIMS Ahmedabad. Our eminent speakers will be throwing light on various aspects of the pathophysiology of the disease, the latest advancements in its management, and much more. Our first speaker for the day is Dr. Vivek Patel, and we will be now moving on with our presentation.
I will be going to talk about the points which are going to favor in as a first line treatment after lifestyle modification in favor of SGLT2 inhibitor. So the today's agenda would be like why metformin has put as a first line therapy, what were the evidence at that point of time when metformin was put as a first line therapy. We all know the beneficial effects of SGLT2 inhibitor. Do metformin interfere with the beneficial effect of SGLT2 inhibitor if it is combined with SGLT2 inhibitor? And lastly, we go head to head. What are the benefits and pros and cons of SGLT2 inhibitor and metformin? So over a period of time, if we see, the evolution of concept of diabetes management has changed. Previously, it was about the glycemic control. We have to achieve a good glycemia. Followed by it came into the picture that the good glycemia should not be harmful to the patient in terms of episodes of hypoglycemia. So whatever the best glycemic control we can achieve with avoidance of hypoglycemia was the initial concept of diabetes management. Later on, the newer and newer pathophysiological mechanism came into the picture. We tried to do treatment according to the pathophysiological mechanism, and therefore that concept of combination therapy, initial early combination therapy came into the picture to target multiple pathophysiological defects. But now what we are thinking, now we are just not thinking about the good glycemic control, but now we are thinking about the extra glycemic benefit which any molecule going to provide to the patient. So in the initial statements, when the metformin was considered as a first line therapy, the statement from the ADA ESD concession statement was that metformin is effective, safe, inexpensive, and may reduce the cardiovascular events. And that this is the first statement regarding metformin when it was put as a first line therapy. What was the evidence at that point of time? The only evidence was the small UKPDS subgroup analysis of 342 patients, which shows that patients who are on metformin has shown a reduction in the cardiovascular events. But by today's standard, if we see the current CVOT trials, if we see the thousands of patients, long-term follow-up, event-driven trial, this subgroup analysis may not be sufficient to justify the cardiovascular benefit of metformin. Even a different study, that is the ADOPT study, has shown that subjects who were receiving metformin experienced more CV events than the glyburide arm, that is the older generation sulfonylurea, though that was not statistically significant. So overall, if we consider these older studies which are not adequately powered to detect the clinically significant difference in CV outcome, it is very difficult because there are a lot of contrary evidence. So why at that point of time metformin was put as a first line therapy? Because at that point of time metformin was competing with whom? Metformin was competing with sulfonylurea, metformin was competing with pioglitazone, AGI, and insulin. There were no molecules which give adequate fight to the metformin at that point of time, and therefore it has put as a first line therapy. But now there is a changing era in the CVOT data, the SGLT2 inhibitor, large number of patients, long-term follow-up, event-driven trials, and have shown consistently reduction in the especially high-risk patient and those patients who have established ACVD, reduction in the 3-point MACE, reduction in cardiovascular death, reduction in hospitalization for heart failure, and renal outcome. Not only this, it has shown even in a non-diabetic patient, the renal outcome, heart failure data, even in a non-diabetic patient. So what are the extra glycemic benefits of SGLT2 inhibitor? First is the CV risk factor reduction. That is the reduction in the weight, specifically the central adiposity reduction is there. Blood pressure, favorable effect. Lipids, favorable effect. Reduction in 3-point MACE, reduction in hospitalization for heart failure. Improved renal outcome, reduction in CV mortality in very high risk patient, especially with empagliflozin. The newer data is coming in patient who are having non-alcoholic steatohepatitis and even obstructive sleep apnea, the SGLT2 inhibitor have shown to improve outcomes. So now the another question is, if what is harm in starting both metformin and SGLT2 inhibitor together? So there is a recent data, recent analysis which has shown, this is the meta-analysis of all the CVOT trials, and as Dr. Manoj has mentioned, that many of the patients were already on metformin. So whether there was any difference between the patient who were on metformin and who were not on metformin, there is definitely a trend toward the better result in those patients who are not on metformin. There is a complex interplay between the AMP kinase and serotonin, which has been implicated that metformin might interfere with the beneficial effect of SGLT2 inhibitor. So this is head to head. If we see the efficacy good with metformin, SGLT2 inhibitor, again, it is a good efficacy, especially when the baseline HbA1c is high. We can see the HbA1c reduction of even more than 1%. Weight benefit, blood pressure benefit, lipid benefit are there with the SGLT2 inhibitor, not with the metformin. Also the extraglycemic benefits, CV protection, renal protection, possible benefits in obstructive sleep apnea and NASH, it is there with the SGLT2 inhibitor. As of any molecule, when we put as a first line therapy, it always comes with the asterisks. Even a metformin, they say the metformin should be first line if patient can tolerate and there is no contraindication. The same is with the SGLT2 inhibitor. We have to look at the contraindication. We have to look at the patient's tolerability. And in a selected patient, definitely SGLT2 inhibitor can be considered as a first line therapy. If we talk about the cost, definitely the metformin is really inexpensive, but with the SGLT2 inhibitor now the other options are also available for a cheaper SGLT2 inhibitor. If we see the clinical journey of SGLT2 inhibitor, as Dr. Manoj has mentioned in his presentation, that from the first use in 1975, 1980, the approval metformin got as a first line antidiabetic therapy in 1985. So it's been 15 years before metformin got as a first line. And it is less than a decade with the SGLT2 inhibitor when it was first used, and now it is already coming just after metformin. The journey has been remarkable. The scope of SGLT2 inhibitor has expanded not only in diabetology but also in cardiology, maybe in near future in gastroenterology, maybe in near future nephrologist. Everybody is going to use SGLT2 inhibitor as a molecule. My only two questions to my fellow speaker would be, if SGLT2 inhibitor would available in 1960s, 1965 with all the data and all the benefits, do you consider metformin as a first line therapy in that era? And if a patient is on a combination of SGLT2 inhibitor and metformin requiring de-escalation of therapy, many of the obese patient coming to us with HbA1c of around 7.1%. Patient started on combination therapy, SGLT2 inhibitor, metformin. With lifestyle modification, patient lost weight. And if we see that patient HbA1c is coming down to 6%, even 5.9%, and patient is requiring de-escalation of therapy, which molecule you are going to stop? Whether it will be the metformin or whether it is the SGLT2 inhibitor you are going to stop. My last thing is that the change is difficult. Always, it has been established for very long, but sometimes change is for better. I would like to have comments from Dr. Manoj Vithlani, sir, for these two questions and attributes.
Thank you, Dr. Vivek, for highlighting the SGLT2 as a big hero. But there is always a caveat. And when you use any drug in a proper indications available, as mentioned by the ADA, that the high risk, severe risk patients, already established SCVD, CKD stage 3, and the heart failure patients. These are the class of the patient must receive as a class 1A evidence. When there is there is a newly detected type 2 diabetes with the HbA1c less than 7.5 and no any additional risk factor, even your CT coronary calcium score is 0, lipid profile okay, no hypertension, nothing, just only a overweight type 2 diabetes patients, newly diagnosed, and with the lifestyle, what will you do? You obviously start with the, will you start with the SGLT2? I will go with the lifestyle modification and metformin. When there is already indication present, then I definitely use the SGLT2. I am not favoring SGLT2, not like that. It's a very good drug, but each and every drug has an appropriate indication. One has to use accordingly and according to the patient characteristics, patient socioeconomic factors. One has to discuss the patient with the side effect. With the most of the time, there is a clinical inertia from the clinician also. Clinician never discuss the side effect profile, never each and everything in detail. When you have to, there is always a patient partnership when deciding the factors, how to use a drug, that we have to do. That's just I want to ask or tell you this only thing.
Thank you, sir. Definitely the HbA1c more than 7%, definitely we all go ahead with the combination therapy. Maybe one of the drug which with the combination would be the SGLT2 inhibitor, because not only in patient who are only having high risk factor, but even in a patient who are having diabetes, even new onset diabetes, it has shown to reduce as a primary prevention the reduction in the heart failure and reduction in the renal outcome. Definitely the benefits are there. So with newer guidelines and newer data coming on, we never know the future, but definitely the SGLT2 inhibitor should be in an appropriate patient. Definitely if there is no contraindication and patient is able to tolerate that molecule, definitely SGLT2 inhibitor would be on board since the beginning to get the patient maximum benefit and longer, healthy, complication-free lives.
Okay, agree with you.
Thank you.
Thank you, Dr. Vivek, for such an interesting session. Moving on to our second session for the day, which is the first line of diabetes after lifestyle modification and the use of metformin by Dr. Manoj Vithlani. Requesting the doctor to please start this presentation.
I would like to start with this first note. This you are seeing the Rohit Sharma and other is the Subham Gill. One is the metformin, old metformin, and the newer SGLT2 inhibitor. Can you label as same? We'll see. Metformin, we all know this is a very time-tested molecule since it's used in 1980. Approval by US FDA got in 1995, but in India we used since years together. Our senior teachers, professor used this drug in enormous number of the patient that they found greatly useful. This is a herbal origin, Gallica officinalis. In UKPD study in 1998, it is a preferred initial agent in type 2 diabetes after the lifestyle modification. Its two characteristics, most important, it's weight neutral or may cause some weight loss in initial phase of the start, and it's very low hypoglycemic risk, reduce the CV events and improve the survival, as we noted in UKPD study and the home study. And good glycemic control efficacy, HbA1c 1 to 2% reduction. And recently, since last 10 years, we have a ample evidence that used up to the eGFR up to 30 ml per minute per 1.73 meter surface area. And we also, with the ample evidence, we know in cancer also it's beneficial. And apart from all of these, economical, quite economical. And this is the slide taken from the up-to-date. Lifestyle changes, decreases the weight and the increase in activity, reduce the HbA1c by 1 to 2. Metformin also reduce the HbA1c 1 to 2. But what's about the SGLT2? Glycemic efficacy, they able to reduce the HbA1c 0.5 to 0.7% after the 3 months with the monotherapy. So the efficacy is also great with the metformin comparing with the SGLT2. And we know that these are the effects of metformin, how it's benefit in the hyperglycemia. It improves the glycemic control, reduce the progression from the IGT and IFG to type 2 diabetes. Insulin resistance also it counters by the several mechanisms that will not go into detail. It reduces the fasting hyperinsulinemia by reduce the hepatic glucose output, stabilize the weight and some weight reduction initially, then it's weight neutral. It improves the lipid profile as well. No significant effect on the blood pressure, but it's maintain the blood pressure those who have overweight patients, and it's counteract the pro-inflammatory state, counteract the pro-coagulant state as well, and anti-thrombotic activity we all know with the decrease in PAI1, fibrinogen and platelet aggregation, and anti-atherosclerosis as well. And this we all know about the era before 2008, that there was no need for the CVOT. After the 2008 and the debacle from the rosiglitazone and the universal consensus world over to need for the CVOT trial, either 3-point or 4-point mass outcomes. So here this one caution must always be exercised in comparing the result of the one trial directly with the another, but these studies interpreted as showing that, and that we all know that SGLT2 especially effective in reducing the risk of the endpoint related with the heart failure and or renal dysfunction, which labeled as the benefit for the pump and the filters. And we all know that the 75% of the patient randomized to the recent CVOT of the SGLT2 were already receiving metformin as a baseline, as a standard of care. And what we all know, the recent updated guidance from the European Society of Cardiology in collaboration with the representative of the ESD, the SGLT2 or GLP-1 should be prescribed irrespective of HbA1c for patients with CV disease or who are at high or very high risk, especially where the risk of the heart failure is elevated for the SGLT2. So here this caveat, all diabetes patients do not require SGLT2, those especially having already CV disease, high CV risk factors and heart failure, and the already having the CKD. Drug new patient could receive one of these anti-diabetic agents as initial glucose lowering pharmacotherapy, in contrast to the current transatlantic diabetes guideline EASD and ADA consensus, which continue to recommend metformin as a first pharmacological treatment after the lifestyle modification. ESC recommendation have proved controversial, not least because of it increased the healthcare cost implied by the adding the expensive branded medication to the comparatively inexpensive metformin. So there is need for the new well-designed clinical trial comparing the metformin with newer agent is needed, but no one will do this type of the trial because there is no economics involved in that. So what we know about the two randomized control trial, UKPDS, overweight type 2 patients on metformin had 39% lower risk of the MI over 10 years, that we all know. In home trial, again, the 392 patients with type 2 diabetes on insulin metformin, along with it, reduced the composite cardiovascular endpoint by 40%. So metformin treatment also reduced the risk of developing type 2 in those who have pre-diabetic also. So these two trial, also a cardiovascular benefit is also already established, that we all know. And this will be another factor in recent COVID era. Metformin treated before COVID, 67% mortality reduction in those already having diabetes and COVID. And this 11% mortality in metformin and versus 24% patient with diabetes not taking metformin. So even with this infection, COVID also is metformin is beneficial. And that's how it's beneficial in COVID-19 as an anti-inflammatory, anti-thrombotic, and which may help counteract the cytokine storm and disseminated thromboembolism. So this is the algorithm from the AACE that it also suggests when there is entry-level HbA1c less than 7.5 monotherapy with metformin. GLP-1 and SGLT2 only recommended when there is a SCVD established case or high CV risk or CKD stage 3 or heart failure with reduced ejection fraction. Then and then these drugs are the useful. Even with the ADA recently 2021 supplements, see the first line therapy is metformin, and then you find out the indicate the high risk patients for the SCVD or established SCVD or CKD or heart failure. Then you can use such new class of the drugs. And this is also a UKPD 34 and UKPD 8, UKPDS 80 reappraisal post-trial follow-up and the randomized treatment with the metformin at least 10 years. This data and any diabetes-related endpoint, diabetes-related death, all-cause death, MI, stroke, PA, peripheral vascular disease, microvascular complication, all favors the treatment with the metformin, which reduce the significant risks and the hazard ratio is favorable on the metformin. So this is my last slide, and the metformin is like the age-old treatment, and then you can think of the other try to investigate for whether SCVD is present or not, heart failure present or not, whether CKD is present or not, and then you decide the adding the new class like SGLT2. And with this note, and you have to think of a risk of the euglycemic decay when you use in old age patients with those who are insulin deficient patients, and risk of vulvovaginitis and genitourinary infection also nearly 10 to 14%. And if you use this patient in frail patient, old age patient, you may end up with the side effect of the SGLT2. So this is the end with my talk, and waiting for my dear friend Dr. Vivek Patel. Thanks for the patience hearing.
Thank you, Dr. Manoj, for such an interesting presentation. Moving on to our third session, which will talk about infections in diabetic patients. And the session is going to be taken by Dr. Surbhi Madan.
Let us start with this talk. We know that diabetes can be ghastly. We have already talked about infections in COVID patients in diabetes. So this is a patient who had a post-CABG graft side infection. This is a patient who had a post ankle fracture implant related infection. So we know that the spectrum of infections in diabetic patients may range from very subtle and chronic infections, starting from foot infections to urinary tract infections to superficial fungal infections like oral candidiasis, vulvovaginitis, intertrigo, to very, very critical and life-threatening infections like mucormycosis, malignant otitis externa, emphysematous cholecystitis and pyelonephritis, pyomyositis and necrotizing fasciitis. So the various predisposing factors in patients with diabetes are, of course, hyperglycemia, which actually is related to impairment of the immune response, vascular insufficiency, sensory peripheral neuropathy, autonomic neuropathy, and skin and mucosal colonization with the pathogens like Staph aureus and Candida species. Now, there are some organisms which have very strong correlation with diabetes. They are Candida, Rhizopus, that is mucor, Burkholderia pseudomallei, if you have heard the name of an infection called melioidosis, and uropathogenic E. coli. Now, this is my first case of a 34 years old female patient who is a diabetic and who presents for a routine workup. And as a part of routine workup in an asymptomatic patient, urine culture is sent, which shows significant colony count for E. coli. So what should this patient be treated with? Should we start an injectable BLBLI like cefoperazone sulbactam or piperacillin tazobactam? Should oral cotrimoxazole be enough or none of the above? So this is a patient with asymptomatic bacteriuria. Though we are saying none of the above, but I think most of us are tempted to start antibiotics in diabetic patients when we have a culture positive with a significant colony count. And so the first thing is that don't send urine cultures in a patient who is even diabetic if the patient is not symptomatic. Because presence of high quantities of a uropathogen in the urine of a diabetic patient is extremely common, and that is called an asymptomatic bacteriuria. Now, the prevalence of asymptomatic bacteriuria is very high, especially in patients like diabetic females and in elderly males. So, when should we treat asymptomatic bacteriuria? Yes, there are few indications. That is, in patients. Okay, so why should we not treat asymptomatic bacteriuria? The reason is that the treatment has no effect on the frequency or in the time to symptomatic infection. Reinfection is common after treatment. So once you treat, the urine will become sterile. And after some time, the patient will again grow the same bug or some other bug. And of course, long-term prognosis with treatment of asymptomatic bacteriuria does not improve. And there is always a risk of antibiotic resistance associated. So when should we treat asymptomatic bacteriuria? In patients who are pregnant, those who are going to undergo any urological intervention, or in renal transplant recipients where actually screening and treatment in the first 3 months following transplant should be done routinely. Similarly, asymptomatic candidiuria should be treated in neonates, in neutropenic patients, and again, those who are going to undergo any urological intervention. Now, this is the case of a 55 years old female patient who is a diabetic and hypertensive for 20 years. She has undergone an angiography and is diagnosed with triple vessel disease. Now we are planning to take her for bypass. Now there is low grade fever which is recorded. However, there is no dysuria. She does have history of urinary incontinence occasionally. Urine shows 40 to 50 pus cells and the culture is positive for E. coli. CRP is high, WBC count is normal, and the next day she gets high grade fever with chills because she is symptomatic. Now there is a group of patients who get post angiography inflammatory fever, which may be related to the dye which is used. So we have to differentiate between inflammatory and infective fever even in such group of patients. So this is a patient who actually needed treatment and we treated her with cefoperazone sulbactam. The next case is a case of a 68 years old female diabetic patient. Now she has history of recurrent UTIs for 6 months, treated with multiple antibiotics including ertapenem, and now she presents with high-grade fever with chills, dysuria for 3 days, right lumbar pain and drowsiness for 2 days. She is febrile, drowsy with significant tenderness in the right lumbar region, and USG reveals gas in the pelvic calyces. She has neutrophilic leukocytosis and her creatinine is high. This is emphysematous pyelonephritis because we have seen gas on the imaging. So urine and blood cultures are sent and meropenem is started. Now this is one of the emergencies in infectious diseases. Emphysematous pyelonephritis presenting as sepsis in a patient who is a known case of diabetes is very bad. So CT abdomen was suggestive of emphysematous pyelonephritis, and as per the guidelines and as pyelonephritis, this kind of pyelonephritis should be made. Basically, emphysematous pyelonephritis, cholecystitis, mucormycosis, all these emergencies in ID, the role of antibiotics is important, antifungals is important, but source control has got the main value in the treatment of all these syndromes. So this patient, ideal should be nephrectomy, but that was refused by the relatives. So she underwent a percutaneous nephrostomy and luckily she did well. She was treated with a long-term course of meropenem and could be discharged after 3 weeks. Now, this is the case of a 55 years old male patient, diabetic CAD with a low ejection fraction. He was admitted in September 2018 with fever and dysuria. This is an old case, and he has history of UTI in the last 4 months after the change of OHAs. So he is on empagliflozin. The purpose of presenting this case is that this is one OHA which is related to the increased incidence of UTIs because of the increased concentration of glucose in urine. So the underlying cause of UTI needs to be changed in this patient, that is change of OHA. Now, this is a 64 years old male who has dysuria, frequency and burning micturition in 2016. Again, this is an old case. And when he started with this UTI, he was diagnosed to have candida in the urine culture. However, many a times candida gets ignored. And yes, candida does not have to be treated all the time in the urine cultures. However, this patient did not have any bacteria. So that is one point which needs to be noticed. Since still he was treated with oral antibiotics, however, his symptoms persisted. Then he had a very prolonged stormy course. He kept on getting UTIs, kept on getting different urine cultures, and various organisms were isolated. In between, he underwent a uroflowmetry, which was suggestive of obstruction. He underwent a cystoscopy with hydrodistension of the bladder. And again, urine culture 1 year later grew the same candida. So this time, for the first time, he received fluconazole. He did have some improvement. However, he continued to have the same symptoms. Somebody started AKT also empirically, but there was no response. And then in September, he was admitted with high-grade fever and chills with us. So this time, he's having pyelonephritis. So we started him on empirical meropenem, colistin, and itraconazole. And at that point of time, I was called in. So looking at his whole history, it's very important to keep in mind that candida also can cause bad infections in diabetic patients. So if you have patients who are not responding to antibiotics, having recurrent UTIs, candida growing multiple times in the urine culture, please think of candida cystitis and pyelonephritis. So this patient was started on fluconazole. However, the culture came positive for candida glabrata. And as you can see here, the MIC for candida is high and there is dose dependent sensitivity. What does that mean is that fluconazole may not be good enough to treat this pyelonephritis. Though fluconazole has got excellent concentrations in the urine, and sometimes we can get away with, treating cystitis with just fluconazole, even in patients who have got high MICs. But in this patient, as the patient is sick and is having pyelonephritis, we changed to amphotericin B, but the patient developed nephrotoxicity, and ultimately this patient was treated with micafungin, which does have better urinary levels as compared to other echinocandins, though echinocandins are not the drugs of choice for candida UTI. Now, this is a patient who is carpenter by profession, presented with redness and painful blistering lesions over the left lower limb with high-grade fever and chills. Hemodynamically, he was stable. So this is cellulitis, and what should be the empirical treatment for cellulitis? No need of BLBLIs like piperacillin, tazobactam and cefosulbactam. Just an amoxiclav and clindamycin is good enough. The next case is the case of a necrotizing fasciitis. Now, how do you differentiate necrotizing fasciitis from cellulitis? Patients have symptoms of toxicity, like they have high-grade fever, they have got lesions which are not looking bad from outside. Patients do not complain of significant, redness and swelling. But when you ask the history about the pain, they have excruciating pain and the progression occurs within hours. So necrotizing fasciitis again is one of the emergency syndromes in ID where source control and surgical debridement is more important as compared to antibiotics. So this patient was debrided and the cultures grew E. coli, which was treated with meropenem for 15 days and he did well.
Thank you, Dr. Surbhi, for such an interesting presentation. So we'll be moving on to our last presentation for the day, which is on the topic management of diabetes in the COVID-19 era. And this session will be taken by Dr. Banshi Saboo.
Organizing committee and scientific committee of JIC, particularly Dr. Anish and Dr. Keyur Parikh for giving me an opportunity to talk about management of diabetes in COVID-19 era. As during this time, we all know that COVID-19 had created a big pandemic all across the country and all across the world. But the major issue is with the persons with diabetes. The persons with diabetes, there was more morbidity, more hospitalization, and at the same time, the management of diabetes became very crucial when these patients were started with steroid therapy also. So what I'll be talking about, a coronavirus, a global pandemic, a special aspect of COVID-19 infection in people with diabetes, and then I will be talking that person with diabetes, they are more at the risk of infection and severe disease infected with respiratory virus. When people with diabetes develop a viral infection, it can be harder to treat due to fluctuation in blood glucose level and possibly the presence of diabetes complication. The patients with diabetes complication, they are in more trouble. Those patients with nephropathy and renal dysfunctions and with cardiomyopathy, there is a more problem. Older people, people with pre-existing medical condition like diabetes, heart disease, asthma, appear to be more vulnerable due to COVID-19 infection, and they lead to more hospitalization also. The immune system is compromised in patients with diabetes and making it harder to fight the virus and likely leading to a longer recovery period. The virus may thrive in an environment of elevated blood glucose level. Now, what is the mechanism which contributes to increased susceptibility for COVID in people with type 2 diabetes? And this is very busy slide, as you can know that the entry of SARS-CoV into the respiratory tract, and this infection of respiratory epithelial that leads to necrosis of respiratory epithelial, mucus production, and increased capillary permeability leads to pneumonia. The pneumonia can lead to ARDS, systemic inflammation, and multi-organ dysfunction. When there is a multi-organ dysfunction, the patients may go in severe conditions, and they may lead to ICU hospitalization, and they may die also. The SARS-CoV itself will also have an impaired neutrophil recruitment, impaired IFN alpha production and NK cells, and impaired macrophage activity also. There is a increase ACE2 expression, which leads to cardiac dysfunction, and it's very important that one side, because of the pneumonia or the lung injury, there could be acute renal injury, and because of increased ACE2 expression, it may lead to cardiac dysfunction also. But all these things happens with in diabetic patients because of dysregulated immune response, and particularly with uncontrolled diabetes, and that leads to cytokine storm, and which may lead to mortality also. So the possible link between diabetes and COVID is, I told you, ACE2 and inhibition of renin-angiotensin system, alteration of the immune system in people with diabetes, ACE and inhibition of renin system, angiotensin system leads to vasoconstriction and inflammation and proliferation and fibrosis, and this binding of the viral complex results in endocytosis and a down regulation of surface ACE2 receptors. So the role of ACE2 and renin-angiotensin system in patients with SARS-CoV infection is very well established, and which is one of the important mechanism by which a patient with COVID infection lead to complication. This ACE2 and inhibition of renin-angiotensin system in healthy individuals, there is a low circulating ACE2. Individuals with diabetes, hypertension, and nephropathy, this circulating ACE2 is increased. So this is one of the important mechanisms that why diabetic patients have more problem in compared to healthy individuals. Many people with cardiovascular complication and nephropathy due to diabetes are prescribed AC inhibitor or angiotensin receptor blockers for cardiovascular and renoprotective effect. So use of AC and ARB may upregulate ACE2, but that does not mean, and there is no data to support that these patients who are on ARB or angiotensin receptor blocker, it should be stopped with the persons with COVID infection. AC inhibitor may increase ACE2 by inhibiting the formation of angiotensin 2 and subsequently its negative regulation of ACE2 also. Mechanism by which diabetes intensified COVID-19 severity is the SARS-CoV directly affecting the host cells who are higher level of glucotoxicity because of a more glucose, which will lead to more oxidative stress, RAS alteration, inflammation, endothelial stress, and apoptosis will increase. This will lead to more progression or severe progression of COVID-19. The alteration of immune system in people with diabetes individuals are more increased risk of infection because of their uncontrolled diabetes due to dysregulation of innate and humoral immune system. The acute hyperglycemia also impairs neutrophil phagocytosis, bactericidal activity, respiratory burst capacity, and formation of granular elastase and myeloperoxidase extracellular traps leading to susceptibility to infection. The hyperglycemia and worse prognosis of COVID-19. Why hyperglycemia is more dangerous during SARS-CoV infection? Role of cytokinin storm, which is well established, and binding of SARS-CoV infection to ACE2. In uncontrolled hyperglycemia, high and aberrantly glycosylated ACE2 in the tissue could favor the cellular infusion of SARS-CoV-2. It leads to higher propensity of COVID-19 infection and higher disease severity. So mandatory to have a fast blood glucose control. So now, rather I will say each and every person with diabetes, they should have a tighter glycemic control. But those patients who have already developed the infection, it is better to get their hyperglycemia as early as they can have a good control, which is better because that decrease of inflammatory cytokinin release, and at the same time it will also have lower ACE2 binding capacity for the virus, and this improves the prognosis in people who are affected because of SARS-CoV-2. Now the challenges in diabetes care in COVID-19, the impact of social distancing, quarantine and lockdown on lifestyle would have probably led to worsening of glucose control. One is because of lack of physical activity. The second is restriction in food supply. So I mean, during this lockdown period, many of the patients or the person with diabetes, they could not get the food which was they were supposed to take. The difficult to get medicine. But the most important difficulty which I think is in last 1 year, the no routine follow-up. So they could not go to their doctors, neither their medication could be up-titrated, and at the same time, their A1C or their regular monitoring was not done. A specific measure, maintaining a good glycemic control will definitely prevent the complication. Emphasis on a regular intake of anti-diabetic drugs and insulin. And we promote, and we had called all our patients also, that those who could not come to our clinic, at least they can have an online consultation also. Emphasis on a care of fit to avoid food-related complication. But sometimes with the persons with food complication or with fit infection, they must visit to their doctor as early as possible because this is a relative emergency condition. Education about the need to visit hospital urgently in emergency situation like vomiting with the drowsiness, shortness of breath, chest pain, weakness of limb, and altered sensorium also. Diet and exercise is very, very important because attention to the nutrition and adequate protein intake is very important. Simple carbohydrates are to be restricted. Care should be taken not to vary the calorie intake markedly because some of them, 50% of them, they were taking care of themselves very nicely and they were really taking care of their nutrition part also very religiously, while 50% of them were not so. And they were taking more calorie or they were taking simple carbs more, and that led to uncontrolled diabetes too. A healthy, balanced diet with a good amounts of protein, fiber, and limitation of saturation fat with restriction of simple carbohydrate and taking more complex carbohydrate is an ideal, healthy, balanced diet. With special consideration for any deficiency of mineral and vitamins so that they should continue to take. Exercise is also very important because that has shown to improve the immunity. Exercise should be continued. Those who could not go out, at least they can do at home. They can walk, they can increase their physical activity. And only during that first time in lockdown period, they could not go out, but in their society or in their home or in their garden, they could walk, or even they can do the cycling and treadmill at home also with stationary jogging and some resistance exercise, which is useful. Coping with hypoglycemia, anti-diabetic regime should be promptly reconsidered following a hypoglycemic episode. Patient could be advised to keep a stock of glucose, which is a glucon D or a glucose tablets which are available with them. Emphasis on a need to take a regular meal following a termination of an episode of a hypoglycemia and with oral high carbohydrates. So if they develop hypoglycemia, they must stop the exercise, they must take the extra carbs and extra simple glucose tablets. That is very, very important. What is the journal recommendation for the management of hyperglycemia in patients with type 2 diabetes with COVID-19? The glycemic goals are very clear. It should be individualized. According to patient age, comorbidities, complication, and clinical severity of SARS-CoV infection, For non-saline diabetic patient with mild infection, fasting plasma glucose should be below 6.1 millimole. That is what we are recommending, that is less than 100. And 2-hour postprandial glucose level, preferably it should be less than 140. With the patients who have older patients with mild infection, this fasting could be up to less than 140 and less than 180. For older patients who are hospitalized with a severe infection, even we want their sugar should be between 120 to 180, but it is not acceptable for them to go more than 240. The glucose monitoring is very, very important. It is an essential part. Even those who are hospitalized, those who are non-hospitalized, those who are in ICU, those who are in room, they should have a very, very regular monitoring. The continuous glucose monitoring is a device which can be used, and it's one of the best way. By distant monitoring also is possible through continuous glucose monitoring, and we can know the continuous graph and complete glycemic pattern in the patients who are hospitalized either in the room, not in ICU setup, or those who are at home. So the remote monitoring was possible through continuous glucose monitoring, but the self-monitoring of blood glucose monitoring is equally important, and that is what advised for all the patients who are hospitalized or even those who are at home. The main goal of in-hospital glucose monitoring are to limit the abnormal glucose variability and minimize hypoglycemia. So one should not go in hypoglycemia at the same time, not even hyperglycemia peak. For tailored therapeutic strategy, should anti-diabetic medication be reconsidered as far as COVID-19 pandemic is concerned? And there are multiple choices. Now, let me talk about the different anti-diabetic drugs. The metformin, as in the patients who are in ICU, those who are severely having hypotension, or so this metformin should be stopped. Or those patients who are in the room, or those who have mild infection at home, they can continue with metformin. As we know that with dehydration or with the patient with a hypotension, it can lead to lactic acidosis. The similar way, the SGLT2 inhibitor can be continued with the patient with mild infection, even with moderate, and those who are in the hospital but not in ICU. Again, the risk of dehydration and diabetic ketoacidosis is always there, and we normally tell that it should be stopped if it is a severe infection or patient is in ICU. The GLP-1, again the same, because it does not allow to eat, and we still we may omit it, but the gliptins can be continued, but GLP-1 analog in the patients who are not eating infection, it should be stopped. The DPP-4 are generally well tolerated, which can be continued, and the best medication is insulin always, and insulin that should not be stopped. Carefully adjusting the dose of insulin in an appropriate way to reach therapeutic goals according to diabetes type, comorbidities, and health status. So why I'm talking of diabetes type, if they are insulin deficient or a type 1, they should be continued with the insulin. If they have comorbidities like renal failure, they should, again can be on insulin. And those patients who have obese, or those patients who are typical type 2 diabetes, even insulin and DPP-4, which can be continued with these patients. What about the glitazone? Because that's again in many important drugs, many of the patients might be on glitazone, which leads to more fluid retention, and it can also lead to heart failure, increased risk of heart failure. So pioglitazone also relatively, those patients who are at higher risk of developing complication, we normally stop. So the metformin, DPP-4, SGLT2, we continue the patient, but with moderate infection or with the problem, SGLT2 can go first. Then metformin can be stopped with the if patient is becoming more serious, and DPP-4 can go last. And insulin is the choice of therapy from mild to severe infection, anywhere for a better control. Basal bolus therapy of a best choice when we are treating the patients of COVID infection who are hospitalized. The key consideration for COVID infection in people with obesity and diabetes, as I told you, the persons with higher chances of morbidity or comorbidity, those who have with SARS-CoV infection, they are more prone to have ICU admission, more chances of mechanical ventilation, and more chances of mortality also in obese patients as well as in diabetic patients. So there are evidence which had shown that these are the patients who should have a tighter glycemic control. We know about the other.
Thank you to all our speakers. The entire team of Docplexus would like to express gratitude for all of you for taking this insightful session. And to all our viewers out there, thank you again for taking time from your busy schedule and coming and attending these lectures on our platform. We will be back again with the next session. We'll keep you posted on that. Till then, please stay safe.